Hi, my name is Sandra, and I'm the lead clinical pharmacist with personalized prescribing. I'm an Ontario licensed Part A pharmacist, and I've been in the field of psychiatric pharmacogenomics for about 4 years now. This is the first forum of its kind by Personalized Prescribing. We're a pharmacogenomic testing company, and we really just wanted to educate healthcare practitioners and also invite questions, feedback, and comments really about what we do and open it up for discussion. So there will be a Q&A at the end of this webinar. We invite you all to ask questions. For the time being, the mics and the cameras will be restricted, but will be reinstated once we get to the question and answer session. So today's topic is the importance of the blood-brain barrier for psychotropic medications, and we're more specifically discussing antidepressant medications and SSRIs today. So let's start with what is the blood-brain barrier? How was it discovered? The blood-brain barrier was actually first discovered in 1890 by a scientist named Paul Ehrlich. What he was doing is he was injecting rabbits with dye and just observing where the dye travels throughout the rabbit's body. And then he realized that the dye did not enter the brain or the spinal cord or the central nervous system at large, hence the discovery of the blood-brain barrier. He in part got a Nobel Peace Prize for this discovery. So the blood-brain barrier is essentially a cluster of capillaries and endothelial cells with very, very tight junctions in between for the passive diffusion of substances into the brain. The blood-brain barrier also has transporters. And these transporters are bidirectional. So there are transporters that help transport substances like glucose into the brain, and an example of that would be the glucose transporter. And then there are transporters like the P-glycoprotein efflux pump, which actually efflux substances from the brain. So that bidirectionality, where instead of going from the blood to the brain, the P-glycoprotein pump actually kicks substances out of the brain back into the bloodstream. So that's what the P-glycoprotein is, and that's what it does. PGP expression has been linked to the efflux of chemotherapeutic drugs in human cancers, leading to multi-drug resistance. So it's not only the brain that expresses this P-glycoprotein pump, even though today our focus is the brain, but it's also cancer cells. Cancer cells actually overexpress P-glycoprotein, which leads to resistance and failure of multiple chemotherapeutic agents that exist and ones that are under review and under trial. P-glycoprotein plays an important physiological role in limiting drug uptake in the gut. So the first encounter that a drug or an orally swallowed medication will have with PGP is at the level of the intestine. So at the lumen, at the intestinal lumen where a drug will be absorbed into the intestine, there's a PGP efflux pump, and it determines how much of the drug, again, depending on your genetic expression of P-glycoprotein, it will determine how much of the drug will be able to enter the intestine. So this is just a little diagram of, I guess, the journey that the drug takes within the body. So at first, the first barrier is that you have the P-glycoprotein pump at the level of the intestine that will determine how much, again, based off of your genetic expression of P-glycoprotein, how much of the drug will enter the intestine and then diffuse into the bloodstream. But there's also a portal vein that connects the intestine with the liver, at which point some of the drug will be metabolized or broken down right away. And whatever then diffuses into the bloodstream is the bioavailability of the drug. Of course, some bioavailability will be lost to protein binding on its way to the brain. And then finally, you have the drug's main barrier to brain entry, which would be the P-glycoprotein transporter or efflux pump at the level of the brain, which very quickly recognizes antidepressants that are substrates. And we'll get into which ones are substrates, but the PGP recognizes its own substrates very quickly, antidepressants with high affinity for the P-glycoprotein pump, and instead of the antidepressant fully permeating into the brain at the concentration it should and occupying the serotonin transporter, it is kicked back out or effluxed back out into the bloodstream, not only causing a lack of efficacy, but also a high side effect burden because, as most of us know, we don't just have serotonin receptors in the brain, but we actually have serotonin receptors in the heart, in the gut, in the groin. We actually have more serotonin receptors in the gut than we do in the brain, which causes the common SSRI side effects like stomach upset and nausea. So the higher efflux activity you have, not only the higher risk of lack of efficacy or treatment resistance, but the higher risk you have of peripheral side effects, which causes a problem with tolerance, which then also leads to poor adherence and then treatment failure. So the role of P-glycoprotein at the blood-brain barrier in the efficacy of antidepressants. So P-glycoprotein is coded by a gene called ABCB1, and depending on your variant expressions at ABCB1, you may have high expression, as the majority of us do. So close to 75% of human beings will have the ABCB1 variant that denotes high expression of P-glycoprotein, which means high efflux activity at the level of the brain. And while generally this is a protective effect, it prevents antigens and bacteria from permeating the brain. When it comes to psychiatric or neurological medications, it poses a challenge. Again, as most of us know, the rate of failure for SSRIs or antidepressants is about 50%. So the STAR-D trial that was conducted a couple of years back actually revealed that only 30% of people will respond to their first antidepressant trial, 50% will experience treatment failure, and another 10 to 15% won't tolerate the side effects. So treatment failure for antidepressants is a big problem, and a lot of it has to do with not only ABCB1 expression or PGP expression, but a lot of it has to do with that. So the Max Planck Institute actually did a big systematic review that I can share with anyone who's interested on the role of PGP and the ABCB1 gene, which codes for the PGP in relation to antidepressant efficacy. So what they did was they studied a whole bunch of SNPs. SNPs are single nucleotide polymorphisms. Single nucleotide polymorphisms are the location on a gene where expression varies from the wild type or from the majority expression and causes a shift. So there was 3 significant findings from this. The first significant finding was that 2 SNPs, RS2032583 and RS2235015, were the SNPs that had the highest effect on brain expression of P-glycoprotein and therefore efflux of antidepressants out of the brain. There was another SNP that had a good amount of evidence behind it, RS1045642, but it mainly affected intestinal entry of the medication. And interestingly, it was the minor alleles, so it was the more rare expressions of RS2032583 and RS2235015 at the ABCB1 gene that codes for P-glycoprotein that were associated with better outcomes, therapeutic outcomes for antidepressants. So it was actually the more rare genetic variants that had a higher likelihood of remission or response. And those are the lower expression P-glycoprotein variants. To be homozygous or to have very, very low expression of PGP. That's about 2 to 3% of the population to have heterozygous, so one allele or one variant that denotes slightly lower expression. That could be closer to 25-30% of the population, and then 70 to 75% of the population actually has the high expression variants. So like I said, it was the minor alleles that were associated with better outcomes, only when plasma concentrations did not exceed the recommended therapeutic range, because you also don't want too much drug entering the brain. For major allele homozygotes, which are the ones with the high efflux capacity, no improvements in clinical outcomes were observed, neither with normal nor high plasma levels. So usually they do these studies in mice. So we don't know how accurate this information is. Compounds that impact the activities of P-glycoprotein. So there are substrates. Substrates are compounds that have a very, very high affinity for being recognized by the P-glycoprotein pump. And then we have inhibitors. Inhibitors actually block the function of the P-glycoprotein pump, either allosterically or non-competitively, or by interfering with the binding site. And then you have inducers. So inducers actually potentiate the function of P-glycoprotein and cause it to work harder to kick substances out of the brain. So interaction between P-glycoprotein substrates, inhibitors, and inducers. Some P-glycoprotein substrates, but not all, actually reduce P-glycoprotein function and can be classed as both substrates and inhibitors. Sertraline, which is Zoloft, is actually a perfect example of that. It's a substrate of the P-glycoprotein pump, but it's also an inhibitor. Zoloft is a very commonly prescribed SSRI medication, and for good reason. It's one of the few that very readily enters the brain, in addition to its very high affinity for the serotonin transporter. Some substances are known to induce P-glycoprotein activity, so are known to potentiate P-glycoprotein activity and actually worsen brain efflux. A lot of the anti-seizure or anti-epileptic medications are actually PGP inducers. Certain antidepressants also induce PGP. Venlafaxine, which is Effexor, is a perfect example of an SSRI that's a PGP inducer, which makes a lot of sense because what I see in clinical practice a lot of the time is this drug working really well for people for about a year, and then they quickly build tolerance to it, and that likely has something to do with induction of PGP. Studies have confirmed that chronic treatment with antidepressants can also alter PGP function. We also know that inflammation increases PGP function, and inflammation is oftentimes one of the markers of major depressive disorder. So suggestions to improve the efficacy of antidepressants with a highly active PGP or high ABCB1 expression. For major allele carriers with no alternative treatment choices, the scientists from the Max Planck Ore group suggest one of three possibilities. The first possibility is to try increasing the dose of the antidepressant, which could cause side effects. Arguably, when you give an individual an SSRI or an antidepressant with very, very high affinity for PGP, it's not that none of the drug is able to passively diffuse or permeate into the brain, but it's that a lot of it is efflux back into the bloodstream. So when you increase the dose, you might have a higher brain concentration, or likely will, but it will come at the cost of an increase of side effect burden. So antidepressant entry or drug entry into the brain or permeation depends largely on the size of the molecule. The smaller the molecule, the better it's able to passively diffuse and cross the blood-brain barrier. It also depends on lipophilicity. So the more lipophilic a substance is, the more likely it's able to cross readily into the brain. Examples of very small, very lipophilic molecules include actually heroin, nicotine, and ethanol. So not all antidepressants have the same substrate value, and it's not that they don't cross into the brain at all, obviously, it's just that there's a high degree of efflux. The second solution is to switch to a non-substrate. So that's probably the easiest solution in my opinion, and the most effective solution, but it may not be the most cost-effective nor the most convenient because the patient has to slowly taper off of the current medication and then slowly titrate onto the new one, deal with those starting effects, and then wait the full 8 to 12 weeks for effect. And then the third solution, and we'll get into that in more detail shortly, is to combine a substrate antidepressant with a P-glycoprotein inhibitor. That way, when the function of PGP is blocked, the substrate antidepressant is actually able to permeate through and enter the brain. Substrate value of a drug. So different antidepressants have different substrate values. Some permeate more easily into the brain and others permeate with more difficulty. So the way that they determined this is that they did mouse studies. So they knocked out the blood-brain barrier in one mouse, and then in the other mouse or the other mice, they kept the blood-brain barrier intact. So you have a knockout mouse, and then you have a wild type or control mouse, and they administered the same drug to each individual mouse, both the knockout as well as the control mouse, and then they compared brain concentrations and came up with substrate values or ratios of efflux versus brain concentration in both the mouse that doesn't have a PGP pump and then the mouse that is completely intact. So ABCB1 substrates, and we'll start with weak substrates, and this is very useful information. So trazodone, not necessarily very commonly used in MDD, more so for sleep, but very, very low substrate value of about 1, crosses into the brain pretty easily. Wellbutrin, bupropion, also very low substrate value. Lamotrigine, and this is actually a really interesting one because of lamotrigine's multimodal indications in treatment-resistant depression and in bipolar disorders. Midazolam, mirtazapine, which can also be taken advantage of more frequently, very low substrate value, and of course sertraline, which is Zoloft. We talked about that. And then another anti-seizure medication, carbamazepine, substrate value of 1.10. Moderate substrates, I find in clinical practice, most people don't have issues. So vortioxetine, Trintellix, it has a substrate value consensus of 1.3, so it crosses in pretty readily. Fluoxetine, which is Prozac, has a substrate value consensus of 1.5, and some literature actually says that fluoxetine is not at all a substrate. So that also is a very viable option for a person with very high efflux at the level of the blood-brain barrier or at the level of P-glycoprotein. And then the strong substrates. And I find that these medications tend to have a very high side effect burden. So paroxetine, fluvoxamine, citalopram, venlafaxine, all very, very high in substrate value. There are some that are not mentioned here that are actually even bigger substrates. Levomilnacipran, Fetsima, I think has a substrate value consensus of around 6. So levomilnacipran is actually one of the highest substrates of the P-glycoprotein pump or of the blood-brain barrier. And vilazodone as well, I believe, has a substrate value of between 4 and 5, fibrid. Newer molecule, also very easily effluxed or very permeates into the brain with difficulty. And those two molecules, both the levomilnacipran and the vilazodone, are better reserved for individuals with moderate or lower P-glycoprotein function or expression. Limitations of using P-glycoprotein inhibitors to help sneak certain molecules like vilazodone or levomilnacipran or even venlafaxine into the brain. Again, using one drug to treat a problem caused by another can sometimes do more harm than good. There are natural substances known to be inhibitors of P-glycoprotein, and we'll get into that shortly. The safest and most widely available natural inhibitors of P-glycoprotein are curcumin, turmeric, and silymarin. These are also anti-inflammatory supplements. They have antioxidant properties. They're very readily available. They can be purchased at a natural supplement store or even at a Costco. Adding pepperine, so essentially just pepper, to both of these substances helps them to become stronger inhibitors because it helps increase their absorption capacity by 2,000-fold. So a dose of 8 grams of curcumin has proven to be safe and effective, but lower doses have been found to be effective, between 0.5 and 1 gram a day, and supplements of curcumin are readily available in those doses. And the same goes for silymarin. Maximum tolerable dose per day is 2.5 grams per day, and much lower doses have been shown to be effective, between 0.5 to 1 milligram a day. So the information about natural substances is actually interesting because we've had patients come in who are on SSRIs and then St. John's wort. And St. John's wort is actually an extreme inducer of P-glycoprotein. And so oftentimes an individual is on an SSRI and then taking the St. John's, and the SSRI isn't doing anything, and it's likely because St. John's wort is actually inducing P-glycoprotein, and there isn't much SSRI entering the brain. So natural substances are a little bit tricky, but these two are known to be potent inhibitors of P-glycoprotein. That about sums up all of the information that I have to share about ABCB1 and the P-glycoprotein pump, and I just wanted to open it up for questions. So questions can be typed out into the chat. The mics are also open in case anyone wants to verbally ask a question. Okay, so we have a couple of questions. I'll start with the first one. Which medications should be avoided with antidepressant therapies? So anything that is a P-glycoprotein inducer should be avoided with antidepressants. So we talked about St. John's wort is one very common inducer. Phenytoin is an inducer of P-glycoprotein as well. A lot of the anti-seizure medications, and it tends to be sometimes be a comorbid condition that a patient will have, or if they have a bipolar type 2 diagnosis. So definitely watch out for the anti-seizure medications in combination with antidepressants, and definitely watch out for St. John's wort. I see another question here. What are the risks of increasing the dose of a medication that is a substrate of P-glycoprotein? So like we said, you will arguably get more of the drug into your brain if you increase the dose, but the problem with increasing the dose tends also to be that you will have more drug being pushed back out into the peripheral system, or a higher concentration of drug being pushed back out into the peripheral system, increasing your side effect burden. Are there any other methods that can be used to ensure optimal brain concentrations of antidepressants into the brain? So the first and easiest method of that would be to use a PGP non-substrate. The second method would be to combine a natural product with PGP, like curcumin, like silymarin. Milk thistle is also a natural inhibitor of P-glycoprotein. There are medications. Someone's asking if there's medications that can inhibit P-glycoprotein. There are medications that can inhibit P-glycoprotein, like verapamil, an antihypertensive medication, or a blood pressure medication. But the problem with using medications or prescription drugs to inhibit PGP is that you cause other problems, like, for example, reducing blood pressure, or like edema or swelling. Ankle swelling is a very common side effect of verapamil, so that would limit its use. There are other medications that also inhibit PGP, but they come with similar risks. So the best route would be to consider natural products. Surprisingly, the statins, atorvastatin, also is an inhibitor of the P-glycoprotein pump. So if your patient has a comorbid diagnosis of cholesterol, or they're taking statins, they might actually have slightly better brain entry. How do we test or identify if a medication is failing because of P-glycoprotein? Well, the easiest and most obvious tell for that would be side effect burden. If your patient is after the 2 to 3 week mark reporting an extremely high side effect burden and not feeling any better, then you know that there's a huge possibility that most of the drug is being pushed back out into the peripheral system or into the bloodstream and interacting with unintended targets and causing side effects or adverse effects. Given the climate of the percentage of high PGP expression being around 70%, it's so important to consider a pharmacogenetic test where possible if you suspect that your patient does have high PGP activity based off of trying 1 or 2 antidepressants and not being able to tolerate them. So that leads me to my next question. Is there a test to see if a patient is having a PGP issue? Yes, you can take a pharmacogenomic test. You can have all of the relevant SNPs at the level of ABCB1, which codes for PGP. You can have that tested. We test how much of the drug will cross into the intestines, and then we also test how much of it will permeate into the brain or cross into the brain thereafter. And if we do find that your patient has high P-glycoprotein activity, we're actually able to tailor our recommendation accordingly. So yes, there is a test. It can be ordered at personalizedprescribing.com, and it would be the psychiatry and pain test. I'm seeing one last question here. How many SNPs does PPI test in relation to PGP? We're actually testing 3 SNPs. So the 1 SNP at the level of the intestines, and then the 2 best studied SNPs at the level of the brain. So if you're having patients that are having problems with high side effect burden, or if you find that you're having patients with having many patients with treatment failure or a high percentage of treatment failure. PGP potential non-substrates include fluoxetine, Prozac, and then inhibitors, sertraline, which is Zoloft. And then weaker substrates are vortioxetine, which is Trintellix. And then the highest substrates are paroxetine, which is Paxil, levomilocipran, which is Fetzima, vilazodone, which is Vibrid, escitalopram, just Cipralex, and citalopram Celexa are also very big substrates. Is pharmacogenomic testing effective? There's no such thing as 100% effectiveness, but we did do a very small case control study with Manulife Insurance, an employer that they provide benefits to, and they found that the test was 82% more effective than treatment as usual. So there's no such thing as 100% because we simply don't know what we don't know, but there's a lot of high level evidence information in a pharmacogenomic test, not only just the metabolic information, which we also provide, CYP2D6 testing, CYP2C19, and then also ABCB1 or PGP permeation or entry, but we also test a lot of other pharmacodynamic genes like the serotonin autoreceptor, the serotonin transporter, and then some postsynaptic receptors so that we can gauge the subsequent effect of increasing serotonin levels in the brain on that individual. And seeing another question coming in, and I'm just waiting for it. Okay, it looks like those were all the questions. I will wait another 5 minutes just in case anyone else thinks of a question that they want to ask. I think that about sums up all of the questions for today. So if you have any more questions, feel free to send me an email at sandra@personalizedprescribing.com. Thank you for your time, and I hope this was useful.